hemostasis. 5 stages of, what? No. Platelet party is definitely one of them. It's not the first one. What? Vasoconstriction. Loud, please. Platelet party. Platelet plug formation. What's the third? Coagulation. 4th? Clot retraction. 5th? Fibrinolysis. Okay, so what we have done is the first 3. The only really complex one of the first 3 was what? Coagulation. Okay, so we talked last time about this, right? 13 different factors. We talked about vitamin K and we talked about calcium. So keep these things in mind because I'm going to tell you some medications for treating clot disorders in a few minutes. Okay, so let's go ahead and finish with the last 2 phases. The last 2 phases are clot retraction and fibrinolysis. Okay, so do you guys remember that generally, if you start the intrinsic pathway, what it starts is the platelets start to aggregate or congregate near exposed collagen fibers, right? Okay, and then usually what happens after that is you're going to form a clot near those platelets, the platelet plug, right? So you're going to have basically all of these fibrin, right, stuck on the platelets. The platelets are kind of stuck to the collagen. So the next phase, guys, let me introduce you to a little bit more about platelets. In addition to platelets having clotting factors, the other things that they have inside them is a little bit of actin and myosin. So what they can do is a little bit of cross-bridge cycling. And here is what clot retraction does. As this tissue starts sending out paracrine agents that say, I'm healing instead of, I am broken, what will happen is it will trigger these platelets to undergo a little bit of contraction. And as they actually start doing cross-bridge cycling, they pull, as they're stuck in the fibrin threads, they pull on the fibrin. I know you're not seeing fibrin in this picture, just imagine it. They pull on the fibrin threads and they pull on the collagen fibers, and what they end up doing is they actually pull the sides of the wound closer together, which makes it easier to heal. Does that make sense to you? When they do that, you might have experienced this if you've ever had a road rash. When they do that, what happens is the scab clot tends to tighten a little bit. Have you guys ever felt it when it tightens? And when it tightens, sometimes you actually exude a little bit of that clear yellow fluid called serum. If you've ever had a nasty road rash, you've definitely experienced that. So that little serum, remember serum is just basically blood plasma minus the clotting factors which stayed in there. So that happens during clot retraction primarily. Does that make sense? Okay, it happens at other times as well, but it happens during clot retraction. So the clot retraction phase is when you pull the edges closer. And the clot retraction phase usually lasts about 30 to 60 minutes. And what happens while you're retracting the clot is you're also repairing the wall of the vessel. Does that make sense? And then how long it takes to repair the wall of the vessel really depends on how much damage was done in a vessel. If the vessel was sliced, it's going to take a hell of a lot longer than if it was a single pinpoint, right? But let's assume that the entire vessel, the wall is healed. Then what you get into is the next phase, which is called fibrinolysis. And the name should make sense to you because, of course, what was the clot made of? Fibrin, exactly. This is the dissolving of the clot once the blood vessel is repaired. And so what happens now is after the vessel has really healed itself, the damaged tissues will start to release something that they didn't release when they were damaged. So these healing tissues, after the damage, after they say, hey, I think everything's cool, I think we might be time to get rid of the clot, they're going to start to release something called TPA, which is tissue plasminogen activator. Tissue plasminogen activator. And what it does, guys, is interacts with an inactive plasma protein called plasminogen, okay? And what it does is converts plasminogen to plasmin, and plasmin dissolves fibrin. Does that make sense? So do you see that this is basically ending the whole positive feedback loop, right? You're like, I need more clotting, I need more platelets, I need more clotting, I need more platelets. Oh, I don't need any of that anymore. And so what happens is the healing tissue says, okay, now it's time to dissolve the clot, right? By releasing TPA. That makes sense to you guys? Okay, so this is always around, it's just inactive. And as soon as you release TPA, you've activated it, and then it can dissolve fibrin. Now, this ends up being clinically important. Go ahead, Charles.
Keep going, because I actually maybe want
to. Okay, this ends up being clinically important because This stuff is massively, massively useful after someone has a stroke and you think that they might have another one. So what you can do is you can administer TPA into the bloodstream, and it can be used as a clot buster, right? They usually, I asked about this, I asked a clinician friend of mine, I was like, why do they not usually administer TPA for heart attacks or pulmonary embolisms, usually only for strokes? And they said that there's a couple of things. First off, it's outrageously expensive, TPA, tissue plasminogen activator. It's also really, really dangerous to use because, of course, it makes it unlikely that you're going to clot anywhere, right? And so what they want to do is they want to save it for situations in which if you had another clot grown, it would really be completely destructive. So heart attack, you might have a second heart attack, but either you'd live or you'd die. But a second stroke, right, could completely change your quality of life in addition to the likelihood of killing you. And it's really expensive. So if you don't have good insurance, they're probably not going to give it to you, even after you have a stroke. So TPA, which is tissue plasminogen activator, this is not a drug that they send you home with or on. This is a drug that is used for inpatient situations only. What was your question?
I was actually wondering, because I work on the neuro at IMC, and we give TPA not often, but for people that had a stroke.
Yeah. Do they use it for anything other than strokes when you've had that experience?
Not that I've seen, and even if they've had a stroke, sometimes even long after the stroke has occurred, they usually don't get it.
Right. It's for like
It's a certain time.
acutely right after a stroke to make sure that you're not still circulating a clot.
3-hour window.
Oh, 3-hour window. Wow.
I thought it was 2.
Interesting. Well, it's probably different for different hospitals too. Yeah.
Yeah, so it's like, it's a very short window.
And I wonder if it's just because, well, that's the time that you could actually break it up before it actually did any damage, or they know, and it's a little problematic because sometimes it breaks a clot into smaller clots, and then you can have secondary complications like embolisms and that kind of stuff. So it has to be pretty damn serious before they're even going to consider it in the first place. I wonder how much it actually costs. Do either of you guys know? No?
Probably find out.
Yeah, I'm sure I could find out too, but I've never actually looked it up. Okay. So let's talk about clotting. Let's talk about inappropriate clotting. So appropriate clotting says you have a hole, you plug it, all is well and good. But we know, of course, that we form inappropriate clots, which is why, one of the reasons, that we might have strokes, heart attacks, and pulmonary embolisms. Okay? So let's just get a little terminology out of the way. A thrombus is a clot that forms in an unbroken blood vessel. It's just a thrombus. If it starts to wiggle and move around, it's called an embolus. But an embolus, by the way, doesn't have to be a blood clot. It's really anything obstructive that could be going through the bloodstream. Like if you go scuba diving, an air bubble can cause an embolus. But in this context, we're talking about a moving clot. Now, let's talk about what prevents a clot from spreading beyond the site of injury. Well, there's a couple of different things that are like hemming in the clot. First off, really, you should only form a clot in a site in which you have really accumulated a lot of these active clotting factors, not inactive ones, but active clotting factors. And in most circumstances, that would occur at the site of an injury, right? And the good thing as far as avoiding inappropriate clotting is that you're constantly carrying away. So there's circulation, right? So they can't really accumulate unless there's damage continuing to make them accumulate. So you're continuing to carry away this clotting factors. In addition, fibrin actually inactivates thrombin as it starts to really, really build up. So here is thrombin right here. As fibrin starts to really build up, it exerts its own little negative feedback on the size of the clot. So it actually starts to inactivate one of the last factors. So that sort of narrows it down as well. And then in addition, you have anticoagulants that are circulating, active anticoagulants all the time. You've got antithrombin 3, which is a plasma protein. You've got heparin. Did you guys know that heparin is an anticoagulant? It's secreted by basophils, which is a type of white blood cell. It's secreted all the time. And so really what it is just a numbers game. Where should you, under normal circumstances, clot? At a site in which you are activating clotting factors far more than you have anticoagulants to hem it in, right? So what it should do, and it doesn't always work, but apparently we're alive, so it does work. What it should do is really keep the clot localized to the damage. But of course it doesn't always do that, so we'll talk about inappropriate clotting in just a second. So you guys have probably heard that heparin is also used clinically. Yeah? Heparin is used therapeutically during surgeries. It's also used as IV locks. They used to use it really commonly as IV locks, but now IV locks are more likely to be saline. But I've heard they still use it in PICC lines and central lines. They use hep locks and PICC lines and central lines. Okay, so heparin, what heparin does is destroys thrombin too. So it kind of does the same thing. So it stops this last little stage, right, of the common pathway. So heparin destroys thrombin, and it's used clinically quite often. It's actually a really, really cheap medication that can be used clinically. It is the medication that I was on my entire pregnancy because of my heart problem. I had a really high likelihood of clotting, and estrogen increases clotting likelihood too, and estrogen stays high all during pregnancy. So I had to shoot myself up with heparin once a day for my entire pregnancy. So heparin is used clinically. And then a couple of other things. You will know, if you don't already, someone who is on blood thinners or anticoagulants because of cardiovascular abnormalities, high likelihood of stroke, history of pulmonary embolism, heart attack, whatever, hypertension. They're not blood thinners. I hate that name because it's not true. It doesn't change the viscosity of the blood. What it really does is it is an anticoagulant. And here is how it's an anticoagulant. It actually is a vitamin K antagonist, okay? And remember, vitamin K was necessary to make this guy right here. Do you remember? Vitamin K, do you remember what vitamin K was necessary to make? It's necessary to make prothrombin, right? So if you give a vitamin K antagonist, then it takes out the first stage of the common pathway and makes it highly unlikely that you are going to do clotting very quickly. And it doesn't take all of it out, this vitamin K antagonist. But Coumadin and warfarin are given as vitamin K antagonists, but you have to be careful with those because, of course, they have side effects, right? And what's going to happen to somebody on Coumadin or warfarin when they run into the coffee table? Ginormous bruise. And then they can't add other antiplatelet plug formation or anticoagulants into their system. Like you're not supposed to eat leafy green vegetables that have a lot of vitamin K in them. Not supposed to take aspirin or ibuprofen because those are antiplatelet plug formation. So you do not want to compound anything that is anti-clotting or antiplatelet plug formation when you're taking those, right? So you are going to definitely run into people who are on Coumadin or warfarin or something else that's related to that. And then the last little one is just, I think somebody may have asked this in this class or maybe the other one. Hold on, my kid's texting me. My husband's out of town this week, so I have to be like extra. Okay, so somebody asked this, and I can't remember if this class or the other class, how if platelets like to start clots even when there's no damage, if they congregate, then how about blood and blood banks when you give blood, right? So we'll just reiterate it even if we've already said it. So all you have to do to keep blood from clotting when you donate blood is use something, this is actually a detergent, and it actually ties up the calcium ions. So what it does is takes calcium out, and without calcium, which of the pathways can you do? None of them, right? So it temporarily just ties up calcium out of the solution, and then as soon as you add it back, their calcium actually provides the calcium that's necessary. So it just keeps it from clotting by doing that simple little mechanism. And there are a lot of different detergents that they use, with the most common one is EDTA. Okay. So, inappropriate clot formation, thrombosis. So, most of your clots form in the deep veins of the legs. So, two questions for you. I know you know the answer, but verbalize it. Why legs? Why veins? Really far from the heart, and what? Relatively low pressure going against gravity, right? So you basically have a lot of reasons that are promoting backflow, promoting slow flow of blood back. So all of us, by the way, will form small clots in our legs. Less clots the more active you are, but they don't usually cause you problems there, and usually our anticoagulants will break them down before they cause any problems. What is really problematic is a combination of forming a clot and narrowed blood vessels. Yes? Because then the clot starts circulating, just like it would in anyone. But if it starts circulating in Lance Armstrong in his prime, his vessels are ginormous, right? So it doesn't ever actually occlude blood flow. But if it starts circulating in someone in their 40s and 50s who has lived on a pork rinds and coffee diet, then what happens? What happens? They've got arteriosclerosis and vasoconstriction, right? So what happens there is the clots form. They just form in anyone, but they don't cause problems unless they actually occlude blood flow by going into a very narrow artery that has arteriosclerosis or atherosclerosis. If you have arteriosclerosis or atherosclerosis, the combination of that clot can cause a heart attack, a stroke, a pulmonary embolism. Does that make sense? Does it make sense to you conceptually now with the physiology all laid out for you, if you didn't already know it, and you might have, why it is very, very unlikely for a person in their 20s to have a heart attack caused by blockage of a coronary artery. But it's far more common in your 40s and your 50s. How long does it take to build up arteriosclerosis? 10, 20, 30 years, right? But what are you doing right now? You are building up arteriosclerosis. The only good part about that is that you don't have to, right? If we talk about the things that can avoid arteriosclerosis in a second, then you can realize that you've got some level of autonomy about it. Okay, so if the embolus gets stuck in a heart blood vessel, it's a heart attack, brain, stroke, or cerebrovascular accident, and lungs, pulmonary embolism. So what are the causes of inappropriate clotting? Many, many of these are preventable. So anything that makes the inner surface of your blood vessels rough or narrow. Of course, you don't want to be an IV drug user if you could generally avoid that, right? Because that infection is going to cause scarring, which is going to make, of course, catching a platelet far more likely. Does that make sense? Right? Keep poking holes in the vessel. It's going to get scars. It's going to be lumpy, right? So IV drug users are at high risk for heart attacks and strokes for the rest of their lives, even after the healing has gone on. High blood pressure. Hypertension stretches your vessels and scars your vessels. So hypertension increases your likelihood of heart attack and stroke, right? And not just busting, but also scarring. And then atherosclerosis or arteriosclerosis, fatty plaque formation. So these are relatively easy to avoid. Of course, most of us are not going to, at this age, decide we are going to become IV drug users, right? But a lot of us might want to consider reducing the amount of fat, sugar, and salt is in our diet, right? And also, of course, we could reduce afterload by increasing the amount of exercise that we do, right? The other thing that causes inappropriate clotting is just letting your blood sit. Like with atrial fibrillation, that's what the problem is. But also, if you have an immobilized patient, one of the reasons that you want to move your patients even when they can't move themselves is because, of course, you're more likely to form an inappropriate clot if you just basically let the person sit there. There's a million reasons you want to mobilize your patients. But the other thing is, if you fly to New Zealand, for instance, it's a long plane ride. How long was it?
12 hours.
Oh, yeah, it's awful. So if you're immobilized for a really long period of time, you're increased likelihood of clot. So you want to get up and wiggle if you can. The plane, they used to try to get you to sit the whole time, and now they don't anymore. It's not because they love you. It's because they don't want you to sue them when you have a stroke or a heart attack after sitting in a plane for so long. So you got to wiggle. Okay, and then this one I put a question mark by because there is not a huge body of evidence to support this, but it's worth considering, especially since there's hardly any negatives to actually considering this one. So one of the things that we think is true because of a small body of evidence is that oxidized cholesterol sticks to the walls of your blood vessels. If you have antioxidants in your system, even a higher cholesterol diet might not be as sticky. So if you have a lack of antioxidants in your diet, the primary antioxidants are C, E, beta-carotene, and selenium. You would get those by eating brightly colored fruits and vegetables or popping a multivitamin if you're living off of ramen, whatever. So what this will do is increase the amount of antioxidants so that you might be able to, for instance, get away with eating an In-N-Out burger, right? So, and the reason I put it here is because this is super easy to do And it wouldn't hurt you to have more antioxidants in your diet for like 5 other reasons anyway. So even though the evidence isn't very strong, there's really no negative to doing that. Okay, the other thing is smoking is a risk factor for 2 reasons. Smoking increases your blood pressure, so increases the likelihood of atherosclerosis and arteriosclerosis. Also decreases the antioxidants in your diet. And like I told you guys, like the most fascinating thing about cadaver dissections with a smoker is that even if they are not obese, their vessels are. Because you can squirt the Colgate toothpaste fat out of their vessels. Every single smoker I've ever had, without exception. So even if their lungs don't look bad, they've got so much fat in their vessels. And then, last but not least, high levels of estrogen. High levels of estrogen, abnormally high levels of estrogen, like during pregnancy, increase your likelihood of clotting. We do not understand the physiology very well, but we do know it makes platelets slightly more likely to congregate or aggregate, which means you're more likely to form a clot. So during pregnancy, the reason I had to do that during pregnancy is because I already had a risk factor, which was atrial fibrillation and a heart murmur. Add high levels of estrogen to that. They were afraid that we wouldn't live through it, so I just shot myself up with heparin the whole time. The old days, by the way, when birth control pills contained a lot of estrogen, they put women at much, much higher risks of strokes and heart attacks and pulmonary embolisms. Now they have figured out the lowest level of estrogen that they can use for birth control, oral contraception. And they don't increase it dramatically, but if you have another risk factor like me, it's probably not your first choice for birth control, right? Oral contraception. In addition, if you go to a responsible physician, ladies, one of the things that they will ask you before they give you birth control is whether you're a smoker, because you do not want to compound 2 different risk factors. And by the way, there are progesterone-only birth control pills now for women who can't have higher levels of estrogen. So anyway, high levels of estrogen. All right, we're done with blood. Respiratory system. Okay. So I do not think respiratory system is hard, but Marissa disagrees with me. Maybe after she hears it the second time, she'll be like, was it hard, Tanner? You didn't think so? Okay. Sometimes the story just makes more sense the first time to certain people. All right. So you guys did respiratory system last week in lab. So let's get the big picture of the respiratory system. Let's see what the forest looks like before we get into the trees. So here's what the forest looks like. It's not outrageously difficult. What we have is we need airflow to go in and out, yes? And air flows like fluids do, from high pressure to low pressure. Everybody with me? Since atmospheric pressure is relatively constant, yeah, doesn't change dramatically. I mean, it changes if you go different elevations, but right now, you're going to have very little change in atmospheric pressure. It's usually around 760 millimeters of mercury, okay? If we want air to go in and out and we can't change atmospheric pressure, what we have to do is change the pressure in our thoracic cavity, right? That makes sense? Do you guys know Boyle's gas law from taking physics ever? It's a super, Okay, it's a super easy one. It basically says if you take a container full of gas and you squish it, the pressure goes up. So if you reduce the volume, it increases the pressure, right? There's an inverse correlation between volume and pressure, right? And if you take a container with gases and you stretch it and increase the volume, then what happens to the pressure? Pressure goes down. Okay, so we use this concept to figure out how to manipulate the pressure above and below atmospheric pressure to cause inspiration or expiration. You guys with me? Okay, so the big picture is really, if I squish my thoracic cavity, I increase the pressure and air goes where? Out. If I stretch my thoracic cavity, I decrease the pressure and air goes in. All right, so that's the basics of ventilation. We'll get into the details in just a minute. It's not harder. But after we get the air in, we need to start doing gas exchange, which is respiration. So ventilation is breathing, respiration is gas exchange. Yes? Okay. All right. So after we get the air in, it's in. Really all we deal with is gradients to move the gases. And it's super easy because on this planet, there is dependably more oxygen in the atmosphere than there is in the pulmonary blood that's going through the pulmonary capillaries, right? So oxygen tends to diffuse straight in, right? And with our respiratory system working properly and on the proper planet, there is going to be dependably more carbon dioxide in the pulmonary capillary beds than there is in our atmosphere. And so carbon dioxide is going to diffuse out. Yes? And then makes perfect sense. Now I've got it how I want it. Send it back to the heart, send it back to the systemic capillaries, and then you pretty much have the opposite exchange, right? Gradient, right? Oxygen moves into the cells, carbon dioxide moves out of the cells, right? You with me? All based on diffusion. So you don't have to worry about transport mechanisms. If you get them to the right area, the gradients will take care of the movement themselves, right? Everybody good? Okay, so, and then we basically just circulate it back and it does the same thing. So we are going to have two things that we need to understand about the respiratory system: ventilation and respiration. Yeah? Ventilation is based on pressure changes. Respiration is primarily going to be based on gradients. Got it. Go ahead.
So with ventilation, people that are in higher atmospheric pressure have shorter breaths?
Have shorter, well, initially, but they'll just regulate. They'll just homeostatically regulate. But yes, if I go up to a higher elevation than I am used to, right, what tends to happen is that I tend to breathe more frequently to compensate for the fact. Yeah? Okay. But then if you let me stay there for a few weeks, I'll just basically make more hemoglobin and readjust my system. Okay? All right. So here we go. We are going to do the steps of respiration first. Okay. So let's just talk about respiration before we get to ventilation. So we're going to have ventilation and respiration. First off, with the steps of respiration, so we're going to start with ventilation to get the air in. And then let me show you this figure. So just stick with me for a second. So ventilation is this part. Yes? Getting air in and out. And then we have external respiration. Stick with me. External respiration is everything that happens at the capillary beds and includes step 1 at the pulmonary capillary beds and step 2 at the systemic capillary beds. That's all external respiration. Internal respiration is the Lord we all serve. It is cellular respiration. Yes? What is generating the concentration gradients that we're dealing with here? What is the reason there is a concentration gradient? What?
Metabolism.
Yeah, it's metabolism. It's cellular respiration. Why do we always, when we get there, have a relatively low concentration of oxygen and a relatively high concentration of carbon dioxide? It's because we're constantly doing metabolism and cellular respiration. So this thing, cellular respiration, is the reason that is driving all of this, right? Because we will never satisfy a cell that is still alive, right? We will never give it enough oxygen, and it will never be done producing carbon dioxide. Everybody okay with that concept? Okay, so pretty sure you guys have heard of cellular respiration before. I mean, maybe once. Okay, so external and internal respiration. Okay, so let's get into ventilation. You guys ready to talk about ventilation? So the big picture of ventilation is simply you are going to use skeletal muscles to change the size of the thoracic cavity. And by doing that, you are going to change the pressure. By changing the pressure, you will generate a flow, right? That makes sense? Okay, so you guys should have known this from anatomy, or you might remember it from wherever. So what muscles do I use for inspiration? Inspiration. Diaphragm and external intercostal muscles. Yes? Diaphragm and external intercostal muscles. Here's what those do. They, of course, the diaphragm pulls down and increases the size of the thoracic cavity. The external intercostal muscles pull up and out and increase the size of the thoracic cavity. By increasing the volume of that cavity, you drop the pressure. And all you really have to do is drop it just a little bit below atmospheric pressure, and then air passively moves in, as long as the tube is open, right? Okay? All right. So, and then with expiration, what we are going to do is primarily, expiration is just relaxation of the muscles and the elastic recoil of the respiratory tract. It's got a lot of elasticity in it. So all I really have to do in order to expire is relax the diaphragm, relax the external intercostal muscles. That will decrease the volume enough that the pressure is usually adequate to cause expiration. But, of course, if you need to, like when you're working out or when you're talking or when you're blowing out a birthday candle, you can decrease the volume more, right? And therefore increase the pressure. And you do that by contracting what muscles? Remember? Forced expiration, internal intercostal muscles, and although nobody ever talks about them, you also use your abdominal muscles to push up on the diaphragm from the bottom. Does that feel right? Because you can feel it when you do it, right? You can feel your abdominal muscles. Okay, now, you don't use contraction of any muscles during normal, what we call tidal expiration. So if you're just sitting there breathing and not talking, you're not using your internal intercostal muscles, right? Tidal expiration is primarily just a relaxation process. Okay, so ventilation is composed of inspiration and expiration. Everybody good? Okay, let's look at the mechanics of it. So if we look at the mechanics of pulmonary ventilation, we will see that basically what we want is flow. And we learned something about flow when we did the cardiovascular system. We learned that the general predictor of flow is F equals the difference in pressure between 2 points over some resistance that you have to consider. Yes? So with cardiovascular system, it was delta P over R because the two P's weren't always the same. Here, it's always going to compare the same two pressures to one another. It's going to compare atmospheric pressure, relatively constant, 760 millimeters of mercury, to alveolar pressure, which is the pressure inside your alveoli, right? And depending on which one of those is bigger, that determines the direction of flow. And the magnitude will determine the speed or the force of flow, right? So I'm exhaling now, but I'm exhaling now with far more flow, right? Because which of these increase dramatically? Any idea? Yeah. That makes sense? Okay, so this one's relatively constant. We don't get to manipulate that one unless we move to a different planet or change dramatically. Okay, everybody okay with that? So F equals delta P over R, but the delta P is always comparing those two. So the changes in pressure are responsible for ventilation. And so air moves like blood does from high pressure to low pressure. It's the same basic equation, but you're always really comparing atmospheric and alveolar pressure. So Boyle's gas law is what we just talked about. It said that if you change the volume of a container containing gases, you change the pressure, right? So let's just see, basically, what we are going to do is we are going to compare atmospheric pressure and alveolar pressure. Where the hell did I put that? There it is. Okay, so let's look at this picture really quickly. So atmospheric pressure is 760 millimeters of mercury. If you drop slightly below it, where will air move? Into the alveoli, right? If you drop slightly below, right? If you go slightly above it, where will air move? Out. Does that make sense? So when you are breathing, all you are really doing is dropping the pressure below for inspiration, popping the pressure above for expiration. Below, above. Do you have to do it dramatically? No. You only have to do it about 1 millimeter mercury above and below in order to cause normal tidal inspiration and expiration. So the muscles of respiration are going to be responsible for this. So let's look at some simple equations for this. Okay, so the only thing that's difficult about this is that you might need to learn a little terminology. P sub ATM is atmospheric pressure. P sub ALV is alveolar pressure. Okay, and there are going to be two more that I will teach you. So atmospheric pressure, as I mentioned, is generally a constant 760 millimeters of mercury. Because they didn't want everyone to constantly have to be saying 759 and 761, all they did is, by convention, you set atmospheric pressure as the 0 point, right? And then you just compare everything to it. We know it's not 0, right? But if we compare everything to it, we say if you drop the alveolar pressure to -1, then air will move in. Yes? In between breaths, when you are not inhaling or exhaling, then alveolar pressure would be what with reference to atmospheric pressure? Equal to, right? Right? Or if you were comparing the difference, it would be 0, right? Does that make sense? So between breaths, what you are doing is you're equalizing with atmospheric pressure, right? But then when you're exhaling, alveolar pressure would be what? Bigger or smaller than atmospheric pressure? Bigger. Yes? That makes sense? So that's all you're doing, guys, right there. In between each breath, it equalizes with atmospheric pressure because air isn't moving anywhere. And then when you're inhaling, it drops below, and when you're exhaling, it rises above, right? So this is like a really simple manipulation that you can see right there. Okay, so The P sub ALV is the alveolar pressure, and at rest it is equal to atmospheric pressure, or it's at about 760 millimeters of mercury. So P sub ALV is sometimes zeroed out at rest. Not saying it's zero, but it's the same as atmospheric pressure. Does that make sense? Okay. So note to self, if alveolar pressure is less than atmospheric pressure, tell me where air is going to move. Alveolar pressure is less than atmospheric. In. Alveolar pressure is greater. Out. Exactly. Okay. So basically, all we are doing is squishing and stretching the container to change the pressure with reference to a constant pressure, right? So it's logical, yes? Okay. So the only other two pressures that we have to consider are these, and this one's kind of hard to grasp, so stick with me for a second. Okay.
This is this what you were talking about?
What?
Okay.
Is that what you said was hard? Okay. So I'll try. I always have trouble with this one too. I have trouble figuring out exactly how to make it make sense. You ready? Okay. So, okay. Diaphragm contracting and external intercostals contracting wouldn't do me a damn bit of good if my lungs didn't stay adhered, right? You with me? So the lungs have to follow what the thoracic cavity does. Everybody okay with that? Okay. But we remember way back from anatomy that the lungs are actually stuck to the wall of the pleural cavity by a double-layered serous membrane, right? The visceral pleura and the parietal pleura with fluid in between. Do you guys remember that? Okay. So in order to make sure that the diaphragm contracting and the external intercostals contracting and increasing the size of the thoracic cavity also stretches the lungs out, right? What I'm going to have to do is to make sure that the lungs stay stuck to the wall, okay? And the way that you make sure that the lungs stay stuck to the wall is the pressure in that pleural cavity right here. Here's the pleural sac. There would be just serous fluid in here, right? Okay. First off, I have to keep it moist because if they are moist, then hydrogen bonding will help them stick together, right? And then second, I have to make it into a vacuum. And so what you do is you make this pressure negative. It is negative 4 millimeters of mercury. Now, that means that if you basically take the visceral and the parietal and you suck the fluid out of them and keep them moist, that means when you contract the diaphragm and pull the external intercostals, the lungs stay adhered to the wall. If that doesn't make sense, then let me show you what happens when you damage that and you lose your vacuum. You ready? So this, by the way, is called intrapleural pressure. It is the pressure in the serous fluid in the pleural cavity, okay? And it has to be lower than anything else so that you have a vacuum. Now let's make that make sense by showing you what happens if you lose your vacuum. Just a second, Toby. Okay, so all is well and good here, and then somebody stabbed him, right? When somebody stabs him, what happens to the pressure in the serous fluid? It becomes equal to atmospheric pressure. And remember, I told you that the lungs are elastic structures. So if you lose, like two microscope slides stuck together, if you lose that pressure, right? If you lose that, they actually collapse on themselves. This is called a pneumothorax, and this is a collapsed lung. And notice that nobody even touched the lung in order to make it collapse. All you had to do was lose this negative pressure. So last question about this, how would you fix this? Yeah, you fix it with a chest tube. And what do? You generate negative pressure, you suck it out, yeah? And then you plug the hole, make sure that the lung doesn't collapse again, and it will regenerate serous fluid, by the way, right? Regenerate serous fluid pretty well, as long as they're otherwise healthy, right? But you gotta plug the hole. Does that make sense to you? Okay, what was your question?
The minus 4 millimeters of mercury, is that 4 below atmospheric pressure?
Yes, 4 below atmospheric pressure,
Okay.
yes. Okay, and it stays adhered best if it is not 1 below atmospheric pressure, because you want a nice difference between what alveolar pressure is and what the intrapleural pressure is. If you leak a little bit, if you get a little bit too much pressure in there, it is going to start to collapse the lung. So what they call that concept, and I don't usually ask, I always ask about intrapleural pressure, the pressure in here that keeps them stuck. Think about microscope slides, right? So microscope slides, when they're wet, they stay really well adhered to one another. If you want them to get wet, vacuum them to one another and then try to pull them apart, right? But this is elastic, so as soon as you stop, it will actually collapse on itself. So the only other pressure that generally is talked about, but I don't usually ask you guys about, FYI, is a comparison between alveolar and intrapleural pressure, and this is called TP, P sub TP, the alveolar pressure and the intrapleural pressure. If that has a decent difference, like -4 difference, then what happens is when you pull, the lungs stay stuck really well and follow. If it doesn't have a big difference, then it's hard to get them to follow what's going on. So basically, you need a decent little vacuum difference right here, or else they won't follow. They won't adhere. So this, by the way, sometimes happens when you're trying to fix a pneumothorax with a chest tube, is that they almost stick, but they don't, because you can't generate a good vacuum in there. So you have to keep sucking them out and plugging the hole and sucking them out and plugging the hole. Maybe they don't collapse completely, but they don't follow dramatically. And if they don't follow, right, if you don't pull the lungs out when you're contracting the diaphragm and the external intercostals, then you're not generating a big volume and therefore a low pressure, right? And it's going to cause problem with airflow getting in and out, right? Because what you need is the lungs to increase, not just the thoracic cavity, but the lungs to increase. Does that make sense? Okay, so that's transpulmonary pressure. So the only one that I hardly ever ask you about, because people do not ever seem to get it, probably just because I teach it badly, because I can't figure out how to make a good metaphor for that one. I've usually got a good metaphor for most things, but not this one, is transpulmonary pressure. All of the rest, you're fair game. Okay? A pneumothorax is a collapsed lung, as we mentioned, right here. So, and with a pneumothorax, you don't even have to touch the lung in order to collapse it. The lungs have a decent amount of elastic tissue in their connective tissue, so they have a lot of snapback. And you want them to have snapback because as long as they are stuck to the walls, the snapback just helps to push the air out of the alveoli, but doesn't pull them apart from the wall, okay? But if you lose that association, that hydrogen bonding to the wall, then they can collapse completely. Okay, so let's talk about the resistance, okay? So resistance is anything that compromises either the ability of your air to get in through the tubes or the ability of your lungs to stretch and snap back so that you can change, right? You can change the volume. So if this is really resisting and you can't actually get much movement, then you're going to get poor flow. So there's two components of resistance. The one is lung compliance. How good are the lungs at pulling out and snapping back and pulling out at snapping back? And the other one is what's happening in the tubes, okay? So what's happening in the tubes, if you change the size of the bronchi and the bronchioles, or if you gunk them up with something, or if you constrict them, or if they get mucus in the walls, then you can change resistance and therefore flow, right? And you can hear people wheezing, right, for breath. If you have bronchial constriction, like with asthma, right? Or if you have mucus accumulation, like with bronchitis, that's going to add to resistance, which causes problems with flow. Does that make sense? Okay, so the size of the ventilation passageways can be affected by bronchodilation or constriction. Under normal circumstances, that's controlled by the autonomic nervous system. Histamine, if you have an allergic reaction, sometimes it actually can cause bronchial constriction, right? Epinephrine is really good for dilating the bronchioles. It's one of the things that happens during sympathetic stimulation. And then mucus accumulation occurs with illness or with irritation. So all of those can change the size of the ventilation passageway. And then the last thing is that, okay, if we look at the inner surface of an alveolus, well, hold on, let's look here for just a second. Okay, so this should stay relatively moist, right? And we know that that's good for keeping it adhered to the wall. But I also want to tell you that the inner surface of the alveolus is also moist. So the inner surface of your respiratory tract is moist. And that's all well and good as long as you can break up the hydrogen bonding if you need to, because otherwise it's going to oppose you stretching your alveoli maximally. So keep that in mind for just a second. Okay, so let's get to some clinical connections. Okay. So what kinds of things can affect whether your lungs really stretch and snap back and stretch and snap back? Well, if you have scarring or fibrosis, like cystic fibrosis, it can thicken the tissues and make it less compliant so you don't stretch as well and you don't snap back as well, which adds to resistance and compromises flow. And then the other thing, and this is important especially with newborn babies, is the inner surface of each alveolus. So this is an alveolus, right? This is the capillaries that would be surrounding the alveolus. Are you oriented? The inner surface of every alveolus is slightly moist, so you're going to have hydrogen bonding. Now, if this were an adult, and an adult actually needs the alveoli to stretch because maybe they're working out and they're actually inspiring quite a bit, it's going to stretch the alveoli, and when you stretch the alveoli, stretching these type 2 cells will cause a detergent to be dumped into the alveolus, and it temporarily breaks up the hydrogen bonding, but it's not a permanent change. So in an adult, when can you actually stretch your alveoli? Well, when you need to stretch your alveoli, right? You stretch them, they dump a temporary surfactant, it breaks up the hydrogen bonding, and then it goes back to normal, right? Okay, so the surfactant interferes with this and lowers the surface tension and increases lung compliance. So deep breathing is actually what causes you to release surfactant, unless you are a brand newborn baby or a premature baby, a baby that was born a little bit early. So a lack of surfactant can cause respiratory distress syndrome of the newborn. So you guys know that, of course, the respiratory system is one of the last systems to come online with a newborn. And so if you have a newborn that's even born, they could be full term, but especially if they're born just a little bit early, what happens is these type 2 cells that you're seeing are not mature and functional yet. And what that does is causes respiratory distress syndrome of the newborn, which is what my son had. So I had a bunch of complicating factors, and he was born about only like 2.5 weeks early. But in addition, I couldn't go through labor and vaginal delivery because of a heart problem, so he had to be delivered by a C-section. Okay. Now, C-section doesn't squish all of the fluid out of their lungs, but the same way that a vaginal delivery would, right? So he comes out, he's 2.5 weeks early, he was delivered by a C-section, and he got this, which is respiratory distress syndrome of the newborn. And what his little chest looked like when he was trying to breathe is he would really, really strain to inhale, but then exhalation is primarily passive recoil and elastic, so his little thorax would really strain to inhale. And he did that a few times. Actually, probably only breathed for about 5 minutes before he popped a mediastinothorax. And his mediastinothorax collapsed his lung, only it collapsed it from the mediastinal side instead of from the outside. He was straining so hard. And so one of his lungs collapsed. And that's all related to the story that we have right here. So what did they do? Stuck in a chest tube, right? Reinflated his lung, plugged the hole. He was in the NICU for 2.5 weeks. And then in addition to delivering oxygen, right, they also delivered surfactant into his lungs. And what did the surfactant do? Yeah, it broke up the hydrogen bonding, right? And so, right, they gave him 2.5 weeks for his type 2 cells to come online and everything to be good, and then he was fine. Does that make sense? But that was, I think both of us were in the hospital for 2 weeks, and it was around $85,000 for both of us. Yeah, so good insurance. Thanks, guys. Thanks for paying my insurance. Appreciate it. Evan, thanks you too. Okay, so the type 2 cells aren't functioning adequately, and so you can have respiratory distress syndrome of the newborn. This is very, very common in preemies, super common. Okay, last little tidbits about clinical connections, or let's do asthma first. Asthma is you get exposed to some kind of respiratory irritant or a pathogen, or it could just be sympathetic nervous system. And the smooth muscle in the bronchioles constricts. And what happens with that is, of course, it adds to resistance and compromises flow, right? Does that make sense? And it can be accompanied by mucus accumulation. If it's not treated for a really long time, it can cause scar tissue formation. And if that happens, it can lead to COPD, which is chronic obstructive pulmonary disease, which is the ones we're going to talk about right now. COPD, chronic obstructive pulmonary disease. Something chronically is causing resistance, which is opposing flow. Okay, what are the biggies that can lead to COPD? One of them is chronic bronchitis, and chronic bronchitis, if you are just one of those people who has a predisposition to respiratory irritation over and over again, the excessive mucus is clogging your airways, and you can get inflammation and fibrosis. And so the problem is, if that's not treated and you can't figure out what's causing it, it can lead to more chronic problems. So COPD can also be caused by emphysema. And emphysema is a really interesting one. So if this is an alveolar bubble, right? You got a whole bunch of little alveoli right there. The first thing that emphysema does, and it's usually in response to chronic respiratory irritation. Smoking is a great way to get yourself in emphysema, but so is working in a coal mine, right? Working with anything that causes a lot of respiratory irritation. There was a really famous case in which a woman had never smoked a day in her life, got emphysema. She worked in the Swiss Miss cocoa factory. You know what happens when you open those things, right? Straight everywhere, right? Well, she got emphysema from working at a cocoa factory, and she'd never been exposed to any other kind of respiratory irritants that they could figure out. So what happens in the early stages is you lose the elasticity, right? Which makes it not as likely to stretch maximally or snap back, right? So you start having resistance problems that cause flow problems. Does that make sense? Okay. And then this is the early stages. In the later stages, you break down the walls of your alveoli, so instead of having a whole bunch, you get big ones. And you lose surface area for gas exchange, which doesn't just cause problems with ventilation, now it's going to cause problems with respiration. Does that make sense? Okay, so emphysema is a really interesting one. Let me show you a couple of different lungs. So here's a lung up close that's relatively healthy. The big holes that you see in there are blood vessels and airways primarily. The rest of it is just really, really tight sponge. Like if you look at an intact, healthy lung, it looks almost like solid tissue unless you look at it under the microscope. If you look at it under the microscope, it would look something like this. But if you look at a lung with emphysema, you can see these things with the naked eye. So instead of looking like this up close, it looks like this up close. Do you see all of those big alveoli that have like joined together? And there are a bunch of big bubbles. We have one of our cadavers on, I think it's this campus, that had emphysema, and his lungs felt so papery when I touched him when I was doing the dissection that I had to cut a little window, and I opened it, and you can see with the naked eye all of the bubbles. Like, I'm surprised that he lived into his 70s. It's so little surface area for gas exchange. You're supposed to have about 750 square feet of surface area for gas exchange, but you can see how much you would lose going from having microscopic bubbles to having big ones. So that's emphysema. And a lot of times when you see people who are, for instance, hauling around oxygen tanks and on oxygen, not always, but quite often, that is the result of chronic emphysema. Because what do you do after that? After you get to the point that they're great big bubbles like this, they don't heal. So if you're having massive problems with respiration, what do you have to do? You have to deliver higher levels of oxygen. Does that make sense to you? Than normal atmospheric oxygen. Okay, so that's emphysema. COPD is usually due to long-term irritation. Air pollution can get you COPD as well. Okay, lung cancer and pneumonia is last two, and then we'll get into respiration. Lung cancer. It accounts for 1/3 of all cancer deaths, but 90% of them are smokers. Would you not be pissed off if you were the 10% that got lung cancer and never smoked a day in your life? You'd be like, what the? Pneumonia is an inflammatory condition in which you start dumping not mucus but fluid inside your airways and your alveoli. And that fluid inside your airways and your alveoli causes problems with resistance, but it also causes problems with gas exchange. Because now instead of just having air between the alveolus and the capillary, I've got a layer of fluid. So you're having trouble with respiration, right? Anybody ever had pneumonia but me? It feels like you're drowning. It feels like you cannot get any air, like you're trying to breathe water. You can't get any in. It's amazing. So it's one of the scariest things. Okay, so now we will get to respiration. You guys ready? Respiration is, again, gas exchange. So when we start doing respiration, we are going to do respiration here at the pulmonary capillary beds, right? We're going to do it again at the systemic capillary beds. And we are going to do it all to serve cellular respiration, right? So we are going to do external respiration, 2 phases, and then internal respiration, which is the same as cellular respiration. But before we get to there, I have to just teach you a little jargon. It's not particularly important, so don't let it confuse you, but it is really commonly used. Okay. So since we are dealing with gases and how gases move in air in addition to in fluids, we are going to talk about gases moving down their gradients, but instead of talking about concentration gradients, they talk about them as partial pressure gradients. So let me just give you this concept and tell you that that 760 millimeters of mercury pressure in the atmosphere is the combined pressure of all of the major gases in the atmosphere. You guys with me? So each gas has its own individual or partial pressure that it's contributing. You with that? Okay, so what is our atmosphere is mostly made up of oxygen, carbon dioxide, nitrogen, and water vapor. We're only really going to be concerned about 2 of those, okay? All right, so the deal is that since we are talking about gases in air, if we heated them up, they would behave differently. If we switched them, they would behave differently. So physicists prefer that instead of just talking about gases moving down concentration gradients, they talk about gases moving down partial pressure gradients. Because you could change the way that they moved if you changed something about their physics. Okay, but we're not. We're going to keep all of those constant. So when I talk about oxygen moving from high oxygen to low oxygen, you will be thinking concentration. They call it a partial pressure gradient. So instead of calling it the concentration of oxygen, they call it the PO2, which is the partial pressure of oxygen. Same thing with carbon dioxide. Instead of talking about carbon dioxide moving from its high concentration to its low concentration, they talk about it moving from its high partial pressure to its low partial pressure, PCO2, okay? But other than that, for us, because we're not changing planets, we're not changing pressure in the atmosphere, and we're not heating ourselves up. This is pretty much the same for your physiology. Okay, so gases move according to their own partial pressures. Oxygen doesn't give a crap what carbon dioxide is doing. Carbon dioxide doesn't give a crap what oxygen is doing. Oxygen is going to move from its high partial pressure to its low partial pressure, and carbon dioxide is going to do the opposite, right? Or move from its high to its low, okay? So the movement of each gas is independent of all of the other gases. That's Dalton's gas law, if you guys care about the physics. Okay, so just keep that in mind and realize that I'm going to use PO2, PCO2, okay? And then you'll be fine with it. Okay, so let's talk about external respiration. It's not going to be hard. So external respiration is composed of 2 steps. We are going to do gas exchange between alveoli and pulmonary capillaries, and then gas exchange between systemic capillaries and tissues. Everybody okay? And once I get it to the tissues, I can do cellular respiration, which will be internal respiration, right? So I'm going to have 2 steps of external respiration before internal respiration. So simply, what we are going to do here is we are going to move things by diffusion, and we're going to move them first across what we call the respiratory membrane. Guys ready? Okay, so what is the respiratory membrane? The respiratory membrane is this combination of the simple squamous epithelium that makes up the wall of an alveolus with a little bitty basement membrane in between it, and then the simple squamous epithelium that makes up the wall of an alveolar capillary. Go ahead.
Is that where you get the fluid for pneumonia?
No, it's inflammatory, the fluid that's produced by these cells, not here. But yes, you do get it here. It would build up right here. So if it built up right here, can you see that it would cause problems with respiration right there?
Yes.
So you would build it in the tubes and in the alveoli themselves. That's why it makes you feel like you're drowning, because you actually do have fluid in your lungs, just like drowning, right? Okay, so this, guys, is called the respiratory membrane. And why is it so effective at doing what it does? Well, first off, I already told you that in a healthy person, it's about 750 square feet of surface area. I've lived in apartments smaller than that, 750 square feet of surface area. And then second, it's incredibly thin, 0.2 of a micrometer or 1/6000th of an inch thin. So really, really thin, high level of surface area. So that's both lungs have that. So we call that the respiratory membrane. It's going to be really, really effective at diffusion. Okay, in addition, one other thing. There's usually a disproportionate amount of blood going through the lungs. So if you got 5-6 liters-ish, usually about 1 liter at any given moment is going through the lungs. So disproportionate blood flow, really, really thin, super good surface area, really good gas exchange. Okay? All right. So the respiration process in the lungs is kind of what you expect it to be. I mean, you already know this. The blood coming to the lungs through the pulmonary capillaries, use the terms PO2 and PCO2. What is high and what is low in the blood coming to the lungs?
Low PO2, high PCO2.
Low PO2, high PCO2, right? And of course, the air coming in that I breathe is low what, high what? Low PCO2, high PO2. By the way, we do breathe in carbon dioxide. As long as it is less than is actually in the bloodstream, then carbon dioxide moves the right direction, which is why you don't want to warm up your car with your garage closed, right? Because then the carbon dioxide and monoxide, but carbon dioxide, right, will build up and then you're not going to be able to actually get rid of it. Does that make sense to you guys? Okay, all right. I mean, I know you knew not to do that, but okay. So blood in the pulmonary arteries, low PO2, high PCO2. It's going to move it through. Blood in the air in the alveoli, high PO2, low PCO2. And so what's going to happen is as the blood goes through, oxygen is going to move in, but not just in, also in and then onto hemoglobin. Yeah? So not only am I carrying blood through, but I'm carrying little oxygen ferries through, right? So in onto hemoglobin. And I am going to take whatever carbon dioxide in whatever form I had, unload it, make it back into carbon dioxide as necessary, and then breathe it out. And I'll tell you about the loading and unloading. Okay, so then, of course, we're going to do circulation. We're going to go back to the heart, right? And then we're going to go to systemic capillaries. And I just want you to think, again, okay, it ain't difficult, but use the right terminology now. Use your P's, okay? The blood going to systemic capillary is high what, low what? High PO2, low PCO2. But the cells, metabolizing cells, Toby, are constantly generating what? High PCO2 and sucking up all of the oxygen, yes? So when you get to these tissue cells, as you get to them, right, what you're always going to run into is you are always going to run into a gradient here that forces, of course, the oxygen to diffuse in and the carbon dioxide to diffuse into the tissues and the carbon dioxide to diffuse out of the tissues. Does that make sense? Okay. So again, this is responsible for the concentration gradient that drives the entire thing. Of course, there's a concentration gradient in the atmosphere as well, right? But if I breathed that in once and didn't have to serve my tissues, I wouldn't have to do it again, right? But the tissues are never satisfied. Your metabolism is never satisfied. So all of this gas exchange is going to ultimately serve internal respiration or cellular respiration, right? And so I've got an animation for you guys that I'll show you guys next time. And the only thing that we have to do on the respiratory system is figure out where the oxygen rides, right? Most of it's in hemoglobin, some of it's in the plasma. And then we'll have to figure out where carbon dioxide rides. Carbon dioxide has 3 different places. Some of it rides in the plasma as carbon dioxide. Some of it rides on the globin as hemoglobin. But most of it actually rides around as the bicarbonate ion. Okay? So we'll do that next time. That's all we have to do with the respiratory system, and then we will start urinary system.
So choking on like a piece of steak would be increasing resistance.
I'm actually going to go